The next session will be Keynote Lecture 5. This session will be chaired by Dr. Jun Inoue. This session is presented by Dr. Henry Lee Kian Chan. Doctors, please.
Hello. I'd like to start the next keynote lecture. It's a great honor to be a chair of the lecture from Dr. Henry Chan. He is Deputy Chief Hospital Manager, Head of Department of Internal Medicine, Head of Division of Gastroenterology and Hepatology at Union Hospital in Hong Kong. And also he is a clinical professor at the Chinese University of Hong Kong. He is now an associate editor of Hepatology International. He is very famous, especially in the area of clinical study of chronic hepatitis B. Today, the title of his lecture is Deciphering HCC Risk Scores for Chronic Hepatitis B. I think he will give us many things useful for clinicians instantly. So, Dr. Henry Chan, please.
Hello, Dr. Inoue. My warm greeting to all my friends in Sendai. I think you all can hear me, right? So I really apologize that I cannot come in person to support this in-person oncology meeting. But I can assure you that I will be in Japan. I will be in Kobe in JDDW next week. So hopefully I can see some of you there. So today, my topic is on deciphering the HCC risk scores in chronic hepatitis B. So let me share my screen with you. Okay. So these are my disclosures. Now, there are many factors affecting the risk of HCC in hepatitis B, and these factors are very complicated and they are interacting with each other. So they include patient factors like age and gender, virus factors like a high viral load, higher surface antigen load increases the risk of HCC. There are a lot of disease factors like cirrhosis, which is the most important disease factor, but there are also other risk factors like ALT levels, platelet, albumin, bilirubin. They all influence the risk of HCC. And recently, there are also emerging data suggesting that diabetes can increase the risk of liver cancer, and of course, alcohol can increase the risk of HCC. But some of these factors are static, but some of these factors changes with time, like HBV, DNA, ALT level, they change with time. And another factor like liver cirrhosis, the assessment may not be easy, and sometimes it is hard to define whether a patient has cirrhosis or not. Now, because of all these complicated interactions and assessment, some investigators try to develop simple scores to assist doctors to assess patients' HCC risk. So what they have done is that they try to collect their own longitudinal cohorts in the hospital. Normally, there will be more than 1,000 patients, and they put all the baseline variables into their computer and find out some independent risk factors of HCC. And from that, and also the weight of these factors of liver cancer, they will derive some score to predict the risk of HCC over time. So these are the risk scores that people are using nowadays. The earliest HCC risk scores were developed predominantly in Asia, and these are the three earliest HCC score published, and most of them were published more than 10 years ago. So they include the CU HCC score, the Hong Kong UGAT HCC score, and the Taiwanese review HBV cohort. They also generate the review HCC score. As you can see, they include a lot of variables, including age and gender, and also some virus variables and biochemical variables. But the most important variable here is actually liver cirrhosis. In the CXC HCC score and the GAT HCC score, cirrhosis is in the equation. But when we work on a review HBV cohort, we think that cirrhosis patients are already at high risk, and we may not need a score for them. So we deliberately excluded liver cirrhosis from the cohort and developed a score for non-cirrhotic. But mind you, all these scores were developed in patients who did not receive antiviral therapy. Now, because liver cirrhosis is so hard to define, so people start to try to use some quantitative measure of fibrosis. And liver stiffness measurement by FibroScan is definitely one of them. So this Korean study clearly show that patients with a higher liver stiffness measurement, that is with a more advanced fibrosis, tend to have increased risk of clinical cirrhosis and also increased risk of HCC. So this is a valid measurement of the patient's risk for HCC and can be a good surrogate marker of liver cirrhosis. The more important group of patients are actually those patients without clinical evidence of cirrhosis, but high liver stiffness measurement. So in another Korean study, they try to define this group as subclinical cirrhosis. So they define subclinical cirrhosis as a liver stiffness measurement of over 13, but there was no clinical evidence of cirrhosis, i.e. they have no hypersplenism, no thrombocytopenia, and on ultrasonography, this patient did not have a clear cirrhotic evidence. So among these 2,800 patients, they found that patients with subclinical cirrhosis, that is a solid line on the Kaplan-Meier curve, has a much higher incidence of hepatocellular carcinoma over a follow-up of 8 years as compared to patients with no subclinical cirrhosis. And they also try to do a lot of subgroup analysis, including patients with normal ALT level, patients with or without antiviral therapy, and they found that this association still held. In other words, liver stiffness measurement is a more sensitive marker of liver cirrhosis than a pure clinical assessment. Now, in view of the importance of liver stiffness measurement HCC risk score, I worked with my colleagues about 10 years ago to modify the CU HCC score into a LSM HCC score. In other words, we kept the old factors like age, albumin, and HPV DNA, but we took away liver cirrhosis and replaced it with liver stiffness measurement. So we validated this in 1,555 patients. Among them, 38 of them had received antiviral therapy, and they were followed for more than 5 years. We found that patients with higher liver stiffness measurement and also higher LSM HCC score had a higher risk of HCC. Now, all these scores were derived in Asia. Of course, a Caucasian would like to validate our scores in their population. So a study published by Harry Youngson's group found that if they apply these 3 HCC scores, namely the CHCC score, GET HCC score, and the RICH-B score, the performance of these scores to predict HCC in Caucasian patients who are under ETV treatment was very poor. So AUROC was only somewhere around 0.55 to 0.75, and even if the scores were tested at 1 year after treatment, the performance was very similar. So initially, they thought that these Asian scores may not apply to Caucasian patients. Of course, now we know that there are many reasons or possible reasons why Asian scores do not work in ETV-treated patients in Europe. First, these Asian scores were derived from untreated patients, and HPV DNA and ALT level are properly irrelevant in any treated patients. So if you use these Asian scores in ETV-treated patients, they may not apply. Second is that cirrhosis may regress on NA treatment. Therefore, because cirrhosis is a very important factor in all these scores, and if one is on any treatment and if the cirrhosis status changes, then it might affect the accuracy of these scores. Now, the third reason, which is always possible, is the difference between Caucasian and Asian patients due to the duration of disease or mode of transmission. We know that most Asian patients acquire the disease very, very early in life. Most of them acquire through mothers to baby, while Caucasians, they acquire later in life, and therefore the risk of liver cancer and the natural history of liver cancer might be a little bit different between Asian and Caucasian. Now, because of all this controversy, the European investigators try to develop their own scoring system. And now comes the very famous PAGE-B score. Now, the PAGE-B score was derived from a data set of more than 1,300 patients in Europe from 8 centers, and subsequently validated in another 490 patient data set in one Italian center. What they found that actually in Europe patients on ETV or TDF, they only need 3 simple factors to predict HCC. One is the platelet count. Lower the platelet, higher the HCC risk. Second is age. Again, older age is a risk factor. And third is gender. A male gender has a much higher risk of liver cancer than female. And based on these 3 factors to derive the PAGE-B score, they found that patient at higher PAGE-B score had a high HCC risk. And no patient developed HCC in 5 years in the low risk group in both the derivation data set and the validation data set. So it seems that PAGE-B score is a perfect score in European patients on ETV, and it seems that cirrhosis is not important. However, when we go back to the original paper that derived the PAGE-B score, in fact, they included 1,666 patients on entecavir or tenofovir. On a multivariate analysis, 4 factors pop up instead of 3. So these 4 factors are age, gender, and platelet count. So these 3 factors were in the PAGE-B score. But the last factor was actually liver cirrhosis. And liver cirrhosis was also a very important risk factor in this data set. And the investigators actually put it down very, very clearly in the PAGE-B score paper that since the diagnosis of cirrhosis may vary among centers and often requires liver biopsy and availability of expert pathologists, the development of PAGE-B HCC score was initially based on the 3 other independent predictors of HCC, i.e. platelet, age, and gender. So in fact, the investigators also acknowledge the importance of cirrhosis and also acknowledge that cirrhosis is very hard to diagnose, and therefore they deliberately took it out from the PAGE-B score. It doesn't mean that cirrhosis is unimportant. So going back to Hong Kong, we try to look into the importance of cirrhosis in the performance of PAGE-B score. So we managed to collect a territory-wide database from 2015 to 18, and there were 32,000 hepatitis B patients on entecavir or tenofovir. 14.4% of them had cirrhosis at baseline, and more than 1,500 patients developed HCC in a median follow-up of almost 4 years. So when we look at overall population, the PAGE-B score had a reasonable performance with AU-ROC for HCC with 0.77. And in a low-risk group, that is the PAGE-B score less than 10, the risk of HCC in 5 years was only 0.5%. In other words, the estimated average annual risk was only 0.1%, which is very, very low. And based on lots of studies, HCC surveillance may not be needed. However, if we just look in the cirrhosis subgroup, that is the 4,600 patient subgroup, we found a significant drop in performance of PAGE-B score. The AU-ROC dropped to 0.63, and HCC risk in the low-risk group was 6.2%, which is not negligible. The annual estimated risk of HCC was beyond 1%, and these patients should be undergone HCC surveillance. So in other words, this study clearly shows that PAGE-B score does not work in cirrhotic patients, and cirrhosis is still important. Now, when you read the EASL guideline for HCC surveillance, in fact, they only also commented all cirrhotic patients should undergo HCC surveillance. Non-cirrhotic patients only at intermediate to high risk PAGE-B score should also know surveillance. In other words, only non-cirrhotic patients with low HB score can be exempted from ACC surveillance. So still, we need to diagnose cirrhosis. Now, a lot of Asian centers also try to revalidate their scores in ETV or TDF treated patients, and many other scores are being developed. And this list is actually not exhaustive. There are more new scores coming up. In other words, these are all scores derived from patients who are treated with NA. So there's one score called M-RICH-B score, one is M-PAGE-B score, the CCAM, and the real B score, and a lot of other factors are involved. And you can see that cirrhosis is almost in every single risk score. And in the M-RICH-B score, actually they use liver stiffness instead of cirrhosis, and it makes it more attractive because we know that cirrhosis is not easy to diagnose, and subclinical cirrhosis is always a headache. So I want to introduce you this modified RICH-B score. In fact, the backbone is RICH-B score. So on the left-hand side, you can see the original RICH-B score, including factors like gender, age, ALT level, neoantigen status, and HBV DNA level. But we know that among ETV treated patients, HBV DNA will be irrelevant because most of them should have a very low or undetectable HBV DNA. Therefore, the modified RICH-B score remove the DNA and change it to liver stiffness measurement. So here on the right-hand side, you can see the M-RICH-B score. There's no HBV DNA in the equation. So look at the performance of M-RICH-B score and compare that with other risk scores being developed. You can see that among patients on anti-oral therapy, ACC in 3 years and 5 years, it has the highest AUROC as compared to any other score derived from predominantly untreated patients. Although we look at the lower panel, among patients without any oral therapy, the LSM-HCC score and M-RICH-B score both make use of liver stiffness measurement to assess cirrhosis, has a better performance than others that requires a clinical diagnosis of liver cirrhosis. Now, last, I want to touch on diabetes. We know that diabetes has been found to be an independent risk factor of liver cancer in many, many studies. And in any treated patient, it's the same case. There are two scores. One is a CAM score, and another real B score. They also found that diabetes should be a factor in this risk score. But I think these two risk scores gives us some insight in how important diabetes is in the entire HCC risk profile in a HBV patient. So you can see that in both the CAM score and real B score, if a patient has no diabetes, the score is 0. But if the patient has diabetes, in both scores, the weight is only 1. A look at the HCC risk strata. For the CAM score, low risk means less than 8. In real B, low risk means 0 to 3. And the one weighting of diabetes is actually very, very small. So in other words, diabetes is an independent risk factor, but based on these HCC risk scores, it's not such an important risk factor to influence the risk of HCC, and other factors like liver cirrhosis and age and gender and other things are more important. So to summarize my talk, I think we know that non-invasive liver fibrosis assessment can identify patients with early cirrhosis. We cannot just rely on clinical assessment to define cirrhosis and assess HCC risk because it's too gross and a lot of time we will be uncertain. Cirrhosis is an important risk factor to consider in treated and untreated patients in all HCC risk scores, including the PAGE-B score. So do not be mistaken that in PAGE-B score, there's no cirrhosis, so cirrhosis is not needed. In fact, it is the investigators who deliberately remove it for the easiness of application. So few scores have integrated liver stiffness measurement into their formula, and they are proven useful in any treated patient. So example is the M-RICH-B score and the LSM-HCC score. So with that, I would like to finish, and I'm happy to answer any questions. Thank you.
Thank you, Dr. Henry Chan. It was a very comprehensive and wonderful lecture. So, any comments or questions from the floor? So, I think the HCC risk score needs both accuracy and simplicity. I think the balance is required. So, do you think which risk score is the best for the prediction of HCC with or without nucleotide analog treatment?
Yeah, thank you. I think right now, HCC risk scores is not widely used clinically, I must say. One reason is because if patients are under the hands of experienced hepatologists, they actually will have some insight into the patient's HCC risk even without calculating scores. So the original idea to develop these scores is actually for general doctors to use it. You know, nowadays we would really like all doctors, even family doctors, to help in the management of hepatitis B infection so that we can eliminate HBV as a public health threat by 2030 as proposed by the World Health Organization. So if you ask me, I still think that those scores with liver stiffness measurement is better. But the problem is liver stiffness measurement is not available in all centers, particularly among the primary care doctors. So the easy thing is we need to diagnose cirrhosis. And if cirrhosis is being diagnosed, well, we found that a lot of these scores perform pretty well. The PHB score is actually quite good and easy to apply if cirrhosis is excluded.
Thank you. So, okay, I'd like to close this lecture. Thank you again.
Thank you very much, and I wish you a very successful meeting.
Thank you.
Thank you. Bye-bye.
Thank you very much, chairs and lectures.